Hi, everybody. I want to talk to you today about my research that I've done over the summer on racial inequities in COVID-19 outcomes. And we've definitely talked in this class previously about the American COVID-19 pandemic and the racial inequities that have meant that Black and Brown people in this country have been dying at a much higher rate than other groups. And as a team of demographers this summer, I worked with people to try and use the case fatality ratio as a way to understand these outcomes and differences across different demographic groups. And the reason we chose to focus on the case fatality ratio is that the mortality rate tells you about how many people are dying as a percentage of the overall population. And so it's a good way of capturing groups that are being exposed to COVID at a higher rate. But the case fatality ratio tells you about people amongst those who have contracted the virus who is dying, and it points to differential access to care or quality of that care, or differences in pre-existing conditions and comorbidities, as well as differences in exposure and ability to take preventative measures. And particularly, the CFR should not be affected by the number of people infected, which is why, as much as it's very important to consider the fact that Black and especially Latino people in this country are being infected at a much higher rate, what's actually happening to those people once they're infected. And just to start us off, here is one key demographic difference in the case fatality ratio. That's the demographic difference across different age groups. As you can see, at 40 to 49, the case fatality ratio is lower than 1%. And it shoots up to almost 30% for people who are 85 plus. As we started to explore the case fatality ratio, we noticed something that's kind of strange at first almost, which is that if you look at the mortality rate, which is what most people have been covering, it is highest for Black, American Native, Pacific Islander, and Hispanic people. On the other hand, the case fatality ratio is highest for Asian and white groups who, as you notice here, have the lowest mortality rates. And to try and understand this, it's important to keep in mind the very different age distributions of people of these different races, as well as the different age distributions of cases. So as you can see, this is a bar graph of cases in Illinois. And in age groups leading up to 60, really, Hispanic populations are the large majority of cases. They're getting infected and comprise much of the infections in these lower age groups. As you move to older populations, it is the white that's here in orange. White people are getting infected at a much higher rate. And so this reflects both the underlying age distribution, which is that white populations on average are much older than others, and Hispanic and Asian populations are particularly young, but also who is getting infected. So it tends to be that Latino and Black people in this country are essential workers or work the sort of positions that do not allow you to work from home. And so working age people of color get infected, while older white people, particularly those in nursing homes, tend to be the ones infected. So with this understanding of how different the age distribution of cases among different racial groups in America is, it's important to find a way to adjust the case fatality ratio for that age difference. And the first step in that, which I'll cover kind of briefly, is actually understanding the data among different states and what data has been shared. And so we did this by performing a landscape analysis where we looked at health department websites from every state, and we created like a scoring system for the sorts of data on cases and deaths that was available based on age and race, and essentially what sort of stratification and what quality of stratification was available. And so this is kind of the result there that you are welcome to talk to me more about, but I won't really focus on today. But essentially what we're looking for is data where you have the age distribution of cases and deaths for COVID-19 specific to each race. So age distribution stratified by each race. That was only available in 3 states as of when we did this research a few months ago. Those were California, Illinois, and Ohio. So among those states where we did have this data available, we performed direct standardization, which you might have covered in your epidemiology or demographic methods classes. And in a direct standardization, you take the age-specific CFRs of each of these racial groups at specific ages, and you apply those to a standardized constructed population so that the distribution of this standardized population is the same across each racial group. And that means that to that standardized population, you're applying the specific CFRs that affect each racial group. And so you should be able to see what different CFRs would look like if each of those races had the same age distribution. And that's the result of doing that age adjustment. And so what's important to point out is here on the left in blue is Hispanic or Latino people. And across all 3 states, they have the lowest unadjusted CFR. And upon adjustment, their CFR rises consistently. And that's suggestive of the fact that they are a younger population than other races. And so their unadjusted CFR is kind of a little under what it truly is. Similarly, but on the other hand of the same thing, the CFR drops consistently for white populations, and that suggests the fact that they are much older, and so their unadjusted CFR is inflated in comparison with other races. Meanwhile, Black and Asian CFRs tend to remain high across the board and tend to kind of keep their ranking compared to the other races as we adjust them. We also created a web app to do this, which I'll cover a different time. So in terms of what our data found, one was that we really did not have enough data to describe this issue and to describe racial inequities. And so in consideration of a federal administration that's tried very hard to prevent people from getting to this data, it's worth pointing out the sort of qualities of data that would truly be helpful in better understanding and navigating this issue. Alongside that, what we obviously found was that there was a need to focus on high-risk populations, specifically elder and especially like elder, Black and brown, and other people of color. And also noticing that, for example, the Asian CFR remained high, and there seems to be some evidence to say that older Asian people are not doing very well with their COVID-19 outcomes. So yeah, this was kind of a way of using demographic methods to look at racial inequities in a pandemic like this.